about healthcare reform, the ACA versus single payer. And at the outset, I'd just like to make disclosures. I don't believe I have any relevant financial relationships with commercial interests, but you should know that I am the chair of the New York Metro chapter and past president of Physicians for a National Health Program, a nonprofit educational and advocacy organization. Frankly, you know, I have received no compensation financially from PNHP at any time. If anything, I've given a contribution to PNHP. So, this is the presentation outline. We're going to talk first about the politics behind the ACA, then kind of list the challenges facing the U.S. healthcare system, and finally talk about the policy options comparing the ACA versus single payer and how each of those approaches deals with the various challenges facing the U.S. healthcare system. I believe that Obama had a fateful choice at the outset of his presidency. You all realize that he was actually advised not to deal with health care in his first year, but he really wanted to deal with health care, but he felt strongly that we should not start from scratch, and he was absolutely right about that. But I believe he had two fundamental choices. The first was to build on the private sector. The second was to build on the public sector, like Medicare. Which did he choose? Any of you have a guess?
One.
Okay, yes, indeed. He decided, in fact, to build on the private sector. And he was following in a tradition that's kind of interesting. Here, for instance, is the first president that, when sitting in office, actually advocated a national health insurance program. Can any of you identify him?
Harry Truman.
That is Harry Truman. Absolutely correct. Did Harry Truman get his national health insurance program?
No.
No. Okay. So it was left up to this chap, who I'm assuming you all know is LBJ, to come along and say, well, let's create a limited form of national health insurance, a program that was limited to people over age 65, namely the Medicare program. And then this chap in the early 1970s, does anyone recognize him?
Teddy.
That's Teddy Kennedy. And he actually proposed in the early 70s to take the Medicare program and to spread it to the rest of the population. But the sitting president at that moment, this chap, Richard Nixon, said, oh, no, we're not going to do that. Let's just mandate that every employer offer health insurance. Did Nixon get his employer mandate?
No.
No. So it was left up to Bill Clinton to propose an individual mandate. And most people don't realize what he actually wrote in the legislation, but here it is. Each eligible individual must enroll in an applicable health plan for the individual and must pay any premium required with respect to such enrollment. That is a real individual mandate. Did Bill Clinton get his individual mandate?
No.
No. So it was left up to Barack Obama to combine these two approaches, an employer mandate and an individual mandate, but he decided to leaven that loaf a little bit by including a public option. You could choose to enroll in a new public plan. In other words, you know, if I don't like the Cornell Medical Center plan that I presently have, I could choose to enroll in the public option. So what happened to that public option? Well, the original robust plan, which was put forth in March of 2009, had open enrollment, that is to say, Medicare for everyone who wants it. It would have Medicare rates, so it would be relatively efficient because it wouldn't have to go out and negotiate with everybody, employer or individual, for a rate, and it would be backed by government. Well, along came Lewin and Associates, a private consulting firm, interestingly owned by United Healthcare, one of the largest health insurers. And it estimated that 119 million people would enroll in this kind of public option. That's curious. You mean not just people who were previously uninsured, right? How many people in 2009 were uninsured? Well, roughly 50 million.
50 million.
So a lot of people like me might not like their employer's plan and actually enroll in the public option. Of course, we should realize that the public option was not single payer because, in fact, all of the multiple for-profit insurance companies would continue to exist, and it should be said that there would be the Medicare program, a Medicaid program as well. So, what was the response? Well, the private health insurance industry and the pharmaceutical companies laid out $1.2 billion on healthcare lobbying during 2009 alone to try to defeat the public option. And this comes from the Center for Public Integrity. This is not my own data. So what happened to the public option? Well, the House plan, which was finally passed in 2009, November, actually had very restricted enrollment. You definitely had to be uninsured, or you could not enroll in this plan. And the Congressional Budget Office went out and estimated that 6 million people, only 6 million, would enroll because there were many, many other restrictions to enrollment. And this entity, the public option, would have to negotiate rates with every provider, hospital, and doctor, and would have to be self-sustaining. That put aside reserves. In other words, it would have to behave like a private health insurance company. Well, even that was too much for the Senate, and I remember this well because on December 24th, 2009, Christmas Eve, the Senate finally passed its plan, and it had no public option. Well, little wonder, because the staffer who had crafted the Senate plan was Liz Fowler, the former vice president of WellPoint Insurance. So what we had now were two plans, one from the House, one from the Senate, one including a public option, one not including a public option. And usually what happens in Congress is that a conference committee is formed and a compromise is worked out. Well, something happened in January of 2010. It was an election. Does anyone remember what that was? It was an election in Massachusetts for Ted Kennedy's seat, and it was won by Scott Brown, a Republican. The consequence of which was that Obama lost his 60 votes in the Senate, and therefore actually decided to take the Senate plan and not have it essentially re-voted upon in the Senate and force it through the House. And that's how we got the Patient Protection and Affordable Care Act, which was finally signed into law March 23rd, 2010. And what was in that law? Well, it was very complicated bill. All sorts of insurance market issues and reform, expansion of Medicaid, issues of guaranteed issue, coverage of kids under the age of 26 on their parents' policies, and a lot of delivery system reform issues, such as ACOs, prevention funds, federally qualified certs. Well, for the rest of this talk, I'm not going to focus on these delivery system things. You can invite me back to do a second talk on those, but we'll focus really on the insurance market reforms. So what did we get in the ACA? We got a mandate model. Everyone is required to have health insurance or pay a penalty. Starting this year, the individual penalty is about $95, but by 2017 it will rise to $395 for singles and $2,085 for families. There is also an employer mandate. If you're an employer with more than 50 employees and you do not offer health insurance to your employees, you will pay in taxes an additional $2,000 per employee. And finally, there is what I believe was necessary. This whole mandate model is necessary for the survival of the private health insurance industry. Because in 2009 alone, it had lost 6.3 million enrollees. And if you looked at the decade before that, they had lost more than 15 million enrollees. They were selling a defective product. You had to force people, frankly, to buy it. And we're going to contrast that with an improved Medicare for all, or a single-payer model. The idea being to build on the original Medicare program, expand it to the entire population, but improve its coverage. Because frankly, there are some real problems with the Medicare program. For instance, in 1965, when it was passed, it did not cover very many preventive services, and there are still gaps in terms of preventive services. It did not cover dental care, and it did not cover long-term care other than 21 days in a skilled nursing home after a hospitalization. But otherwise, no coverage for long-term care. The third point would be to eliminate deductibles and co-payments, which are substantial in the Medicare program. Fourth, expand drug coverage, essentially really dealing with the limits of Part D, which now has to go through private insurance companies, essentially putting it through the Medicare public program. And finally, we might do some redesign of physician reimbursement. So what we're going to do now is contrast these two approaches to healthcare reform when dealing with the challenges facing our healthcare system. Declining access, escalating costs, the lack of comprehensive benefits, restricted choice, uneven quality, insufficient primary care, and finally we're going to have to figure out how we pay for all that reform. So let's start with declining access. And indeed, what you see here on this slide is that since 1976 up through about 2011, we've had about 1 million more people become uninsured in the United States. Yes, a little dip here in the 1980s when the Medicaid program was expanded, and a little dip here at the end of the 1990s the state child health insurance program was created. And yes, again, in 2011, a little bit of a decline here when children up age 26 could be, in fact, covered by their parents' policies under the ACA. But I think that's only part of the problem, because there is now an epidemic of underinsurance.
Right.
If you spend more than % of your income on health care in any one year, you don't have enough health insurance. And if we look at the year 2000, you'll see 42 million people, in fact, were underinsured, and most of those people actually had health insurance. In 2007, that number had gone up to $62 million, and in 2012, 62 million people, and in 2012, it was up to 80 million people. We have a problem with people being underinsured. Little wonder that 62% of all personal bankruptcies in the United States are due to medical expenditures, and over 75% of those people had health insurance at the outset of their bankrupting illness. Why did they go bankrupt? Any ideas?
Couldn't meet deductibles.
Okay, so they may have actually been underinsured, but probably there was another feature, and that is that they got so sick, what happened? They lost their job.
Oh, yeah.
And what happens when you lose your job in the United States?
You lose your insurance.
You lose your health insurance. The only industrialized nation in the world where that happens. So, how does an improved Medicare for all deal with this problem? Well, I think two essential words you should look for in legislation is that there be automatic enrollment. You present to the emergency room of a hospital. They do their wallet biopsy on you and find out you have no health insurance. Well, what a wonderful opportunity. Let's sign you up for the National Health Insurance Program. Is there any private health insurance that would sign you up in the emergency room of a hospital? No way. And it ought to be a federal guarantee, and probably the most controversial thing I'll say this evening is that I think it ought to cover all residents of the United States. That is to say, even the undocumented. Oh yes, we might put some restriction in there that somebody had to prove residency for 9 months or a year and a half, so that people wouldn't just flock to the United States to get health care. The mantra should be everybody in, nobody out. Well, how does the ACA deal with this problem of access to health care? First, it mandates the purchase of private health insurance, and that's begun, as you all know, this year, 2014. But it also expands Medicaid eligibility up to 138% of the federal poverty level. That would mean $15,856 for a single person and up to $26,951 for families. But it does not do that in 24 states because the Supreme Court said that, in fact, states could not be compelled to expand eligibility in their programs. And yes, it does subsidize premiums up to 400% of the poverty level, and those are much more respectable incomes that you see here, through tax credits and so forth. But these are subsidies that are still being defined in various parts of the country. And yeah, there are finally some insurance market reforms that are good things. You know, coverage up to age 26 on your parents' policies. no pre-existing condition exclusions, no annual or lifetime limits. So what happens in terms of access under the ACA? What you see here is that by 2019, we will still have 29 to 30 million people that are uninsured. The ACA does not guarantee universal coverage. Well, what about escalating costs? You know, that's something that we think our private system should be dealing with. Well, here you see that since 1999 up to 2011, premiums went up 160%, and the employees' contribution to premiums went up 168%. Employers were shifting the cost to their employees. At the same time as employees' income only went up 50%, and 38% of that was consumed by inflation. Little wonder that the most common reason that a union goes on strike these days has to do with the employer's attempt to shift the cost of health care onto the employee. And indeed, health care is really expensive. Here is the national average premium on a yearly basis for an employer-provided insurance plan, which is probably one of the least expensive plans you can get because the employer can negotiate with the insurance company for a group of people. And what you can see here is that single coverage is $6,025 per year. Family coverage is up to $16,834 per year. And the employee contribution now is over $1,000 if you're a single person, and close to $5,000 if you're covering a family. So, how does an improved Medicare for All deal with this kind of problem of costs? Well, it has really low administrative costs because it's a single payer. If you look at Medicare, which is an example of a single payer program, it has an administrative cost of 2 to 3%. That is to say, the cost of the bureaucracy to run the program. That means that 97 to 98% of the dollars collected by Medicare actually go out to pay doctors and hospitals. Not true for private insurance, which has an overhead and profit, dividends that it has to pay, and so forth, of 16 to 30%, meaning that, in fact, it can be true that only 70% of the dollars collected in premiums go out to doctors and hospitals. In this article in the New England Journal of Medicine, and we've kind of updated the data here, it is estimated that $400 billion could be saved by converting from our for-profit private health insurance system to a Medicare for All single-payer system. We could cover everyone who is uninsured today without increasing the overall cost to the system. Where do those savings come from? Here's a study by Lewin and Associates, the group that we talked about earlier, that estimated 119 million people would enroll in a public option. And what you can see here is that, yes, it costs more, 6.4%, to cover the uninsured and the poorly insured, and it costs more if you're going to eliminate, essentially, co-pays, deductibles, cost sharing, 5.1%. But you get some major savings, not only from insurance company overhead, that's 5.3%, but also from hospital administrative costs. We compared Toronto General in single-payer Canada with the Mass General in Boston, and what we saw at similarly sized hospitals, by the way, was that there were only 3 billers up there in Canada and over 300 billers at the Mass General. That kind of saving could be realized if we went to single payer. In physician offices, in my office, I have to hire additional people, to deal with the denial of claims, to deal with, prior approval processes, the challenges that my patients face around getting prescription drugs and things of that sort. Under a single payer, we would have much less of that. And then there's the bulk purchasing of drug equipment. What entity in this country gets the lowest price on drugs? Does anyone have a guess?
The veterans.
The Veterans Administration. Why? Because it can negotiate directly with the pharmaceutical industry. And yes, we could really put in a primary care emphasis and reduce fraud. And so what you see here is that you could actually save money by going to single payer, 4.3% of the total cost. And, that's a really exciting possibility. I love this slide because it kind of illustrates that. Here you see the increase in the number of physicians in the United States from 1990 to 2010. But look at what's happened to the number of administrators. We need to amputate that group. Give them meaningful work instead of pushing papers and denying claims. Let's really have them dealing with and delivering services. And here from Carl Schramm, a conservative economist, he agrees with our estimate that Medicare has an overhead of about 3%. But commercial insurers, for-profit private insurers, have a 19.9%. That's, by the way, what convinced me he was conservative. He wouldn't say 20%, right? And when a nonprofit blue, oopsie daisy, converts to a for-profit blue, its administrative costs go up. And single payer offers tools to bend the cost curve in the long run. Global budgeting of hospitals, capital investment planning, an emphasis on primary care and the coordination of care with alternative ways of paying for care, and frankly, bulk purchasing of pharmaceuticals. Well, what does the ACA do about healthcare costs? It's essentially a market theory. The idea being, if you mandate the young, healthy, uninsured people presently, if you mandate that they buy private health insurance, since they usually don't get sick, they're not going to use their health insurance, they're low risks, then it should be possible that the premiums for everyone will go down. Well, is this a realistic assumption? I just thought that premiums are huge, right? And that penalties are really not that substantial. I wonder, frankly, whether or not there won't be a whole group of people who, rather than pay the premium, will in fact pay the penalty. And the ACA offers a few unproven tools to contain costs, such as health information technology, electronic medical records, but that's going to cost money up front. It's not going to save money initially. Or chronic disease management, a wonderful program that Ed Wagner has put forward in Oregon, but never really submitted to a randomized trial, and I'm not sure it will save money. And then there are all the payment reforms that you've seen broadcast in the media, ACAs, O's, bundled payments, value-based purchasing. Frankly, none of them submitted to a good trial in terms of saving money. And little wonder that, the CMS actuary, the Commonwealth Fund, the Congressional Budget Office, all estimate that by 2019, we may be up to close to $4.5 trillion, and roughly 20 to 21% of our gross domestic product being paid for health care. The ACA, I think, will not control costs. Well, what about the lack of comprehensive benefits? Always think of benefits in two regards. One is the services. Does it cover doctors, nurse practitioners, hospitals, drugs, dental, mental health, home care, and nursing home care? And how does it cover financially? What are the size of the copays and the deductibles? In an improved Medicare for all approach, we would want very comprehensive services. Everything from preventive care, hospital and physician services, down to home care and nursing home care, all medically necessary services. Would there be any exclusions? Oh, sure, tummy tucks, Botox for wrinkles, but they should be very limited. How would these things be decided? That's a controversial question, but one could imagine a payment board that included patient representatives, patient advocates, doctors, hospitals, maybe even some of the pharmaceutical industry. And an improved Medicare for all would eliminate copays or deductibles. Why? Because frankly, virtually every study that's been done show that they reduce needed care equal to unneeded care. And they clearly result in the underuse of primary care services. And I would argue they're not as effective in reducing overuse of technology-intensive services as other interventions. For instance, truly eliminating the self-referral to MD-owned facilities. You've all heard of Atul Gawande's article on McAllen, Texas, where he says it's very, very expensive, but he fails to point out that the problem there was that the MRIs, the CT scanners, the laboratories were all owned by the doctors who were making the referrals. We should eliminate that kind of situation. We could also figure out strategies for reducing defensive medicine. Well, how does the ACA deal with this issue of benefits? Frankly, there's no standard benefit package mandated. Yes, there are the 10 essential benefits that the IOM put together, but they are categories of things: hospital payment, physician payment, pediatrician and OBGYN payment. But there's no true standard benefit package. Yes, the ACA eliminates copays and deductibles, but only on preventive services. There is a stipulation that health insurance must have a medical loss ratio of 80 to 85%. Have you heard about what this medical loss ratio is?
Yeah.
It's fascinating. It's a creation of the private health insurance industry that they now don't broadcast too loudly. Because the way they look at it, from the perspective of the private insurance company, is that every dollar they spend on a doctor, a hospital, a prescription drug, is perceived as a loss. Wow. What are they in business to do? Frankly, to make money. So, and finally, there is no regulation, frankly, of the magnitude of premiums, deductibles, and copays, just the stipulation in the ACA that benefits must have an actuarial value of 60% or higher. And what does that mean? Well, it's kind of fascinating here. You've heard about the different or metal plans. Here, a platinum plan, I think, tells you essentially that the insurance company pays 90% of bills, and you only pay 10%. A gold plan is 80, and you pay 20%. A silver plan, 70% by the insurance company, 30% by you, and an insurance plan that's bronze is 60%, and you pay 40%. By the way, in most of the exchanges, you have to be in the silver category in order to get the tax deductions on premium payments. So that I think you're relatively underinsured in that setting. And what I really fear is that the average employer plan today is roughly at 87% of actuarial value, that we're going to find that forced down to somewhere in the 70s. Here in New York, for instance, our New York State exchange, their bronze plan has a $6,000 family deductible, a maximum out-of-pocket payment of $12,700, and you have to pay 50% co-insurance for ambulance, emergency room, urgent care, advanced testing, diagnostic test, dialysis, hospice care, end-of-life care. I mean, you know, this is not going to be easily absorbed by a patient who is on these exchanges. The fourth challenge is restricted choice. 42% of employees in the United States have no choice. Why is that? Because their employer offers how many plans? One. Right. I don't call that choice. And in fact, the employer plan, as a private health insurance plan, limits the patient's choice to a network of doctors and hospitals with whom the insurance company has negotiated contracts. And if you go out of network, you pay substantially more. So we have a real problem with choice. How does an improved Medicare for all deal with that? It expands choice for everyone. There would be no limit to a network of providers. There would be free choice of doctor and hospital. We would be able to de-link health insurance from employment and join the rest of the industrialized world. How does the ACA deal with this issue of choice? Well, through the creation of health insurance exchanges, it expands choice for some. But enrollment is frequently limited to those in the individual and small group market. Yes, they have a marketplace of private health insurance plans, but no public option. Some of these are state-based, and, you know, the national plan is not universal. And the legislation clearly says no state single-payer plan would be allowed until 2017. Well, don't tell that to the state of Vermont. They went ahead and elected a governor that's in favor of single-payer, a legislature that's in favor of single-payer, and they're using the ACA to move themselves through these three stages such that they will be ready in 2017 to create a state single-payer. And we here in the state of New York have a state single-payer bill called New York Health, put forward by Richard Gottfried, the chair of our health committee in the Assembly, and it has the principles of a single-payer plan, including funding through a graduated payroll tax. And we're struggling hard here to move that forward. We have hearings going on starting in December in Buffalo, Rochester, Syracuse, New York City, Long Island, and Albany. And we really are optimistic maybe this year the Assembly will be a single-payer bill. Will we get it through the state Senate? Not given the electoral results yesterday. So challenge number 5 is uneven quality. In 2014, the U.S. was the last among 11 industrialized nations in health system performance, quality, access, efficiency, equity, and healthy lives. And we've gone backwards because in 2004, we were 5th. So what does an improved Medicare for all offer in terms of quality? Well, we finally have a national database on healthcare quality. One of our real problems today is that private health insurance companies view their quality data as proprietary information. Little wonder, because if they reported poor quality, probably many employers wouldn't buy their product. Under a single payer national health insurance program, we'd be able to have national standards and public reporting. And what I would like to see is that everybody get a little credit card-like thing that had their, blood pressure, their EKG, their latest blood tests, a list of the operations they've had, a list of the medical problems that they have. Impossible, you say? Absolutely not. Just go and visit Taiwan. I was there last year, and that's what they have. Everybody has their little healthcare credit card. How does the ACA deal with quality? Well, there's some good things here. They subsidize, comparative effectiveness research. There's the creation of the CMS Innovation Center to test new payment and service delivery models, such as patient-centered med homes and ACOs, value-based purchasing, where hospital payments are based on quality reporting measures, readmission penalties that are going into effect this year, and reduced hospital payments for hospital-acquired infections in 2015. Will these be really sufficient to improve the quality of our system? I fear not. And challenge 6 is the insufficient number of primary care physicians in the country. And a little wonder, because here you see the average medical school debt for a graduating senior is $160,000. And since primary care is under-reimbursed, we are finding that more and more medical school graduates are going to the specialties. How would an improved Medicare for all deal with this? We could think in terms of free tuition to medical school. This is a complicated proposal that the national PNHP has not had a position on, but it's something we could talk about in the question period. There could be debt forgiveness for people who go into primary care. That happens now in federally qualified health centers. And we could begin to pay for malpractice premiums for those who went into primary care. And that's also something that happens in federally qualified health centers. And then there are patient-centered medical homes, team-based care, open access, coordination of care, greater use of phone and internet medicine. All things that I think we could do if we had an improved Medicare for all program. What does the ACA do in terms of primary care encouragement? Well, 10% primary care bonus. This amounts, we calculate, to about $4,000 to $10,000 per provider per year. Not enough, I think, to induce many doctors to go into primary care. A good thing is in Medicaid payment to Medicare rates for primary care. And yes, this thing called the Independent Payment Advisory Board, which actually hasn't been formulated as far as I know. although it was scheduled to go up this year. And finally, there's the challenge of how to pay for all of this reform. And under a single-payer improved Medicare for all, the major way would be through public funding. We could use a graduated poll tax, corporate and income taxes. We could even tax unearned income, such as dividends from stocks and bonds. But we would not charge premiums. Why? Because premiums are so regressive. The president of the company pays the same premium frequently as the secretary, and yet their incomes are so widely different. Under this kind of an approach, there would be no increase in the overall health care spending because of all of those administrative savings that we talked about earlier. And this would be essentially a non-profit private delivery system for local control. It's important to say this is not socialized medicine. That is to say, we're not proposing that doctors be salaried by government or that hospitals be owned by government. That's socialized medicine. We're talking about a publicly funded, privately delivered partnership. Well, how does the ACA pay for its reforms? Through increased taxes. Some of those on what will go into effect in 2018, what is called Cadillac health insurance plans. Those are the ones that unions have negotiated. They're the ones with the most comprehensive benefit, highest actuarial values. Good idea. Medicare payroll tax increases go into effect such that 10.45% of your income, you will now put in 2.35% if your income is over $200,000. And there is, yes, interestingly, a tax on investment income of 3.8%. And then, of course, there's from the Medicare program, the Advantage plans, which are presently overpaid, over 10 years will be paid less. There will be a cut in the disproportionate share payments to hospitals because presumably more people are getting covered. And yes, what we'll see is a cut in payments to nursing home and home care. Not necessarily, it seems to me, a good thing. And as many bills do, they talk about cracking down on fraud and abuse. So, in summary, what do we have with the Affordable Care Act? We have expanded coverage but not universal, cost control by market means, no definition of benefits, risk of increasing underinsurance, choice through state-based exchanges but no public option, primary care and ACO pilots, and funding through an excise tax on high-cost comprehensive coverage and Medicare cutbacks. Well, what happens if we go for a single-payer Medicare for all approach? This is the physician's proposal, which is now a decade old and is being rewritten and we hope will be published shortly. And it says essentially that there should be universal coverage through automatic enrollment, low administrative costs because it is a single payer, comprehensive coverage without copays and deductibles, maximum choice of doctor, nurse practitioner, and hospital, improved quality through nationwide HIT, expanded primary care, publicly funded and privately delivered. My Cornell students tell me I ought to call this Medicare 2.0. And yes, we have bills in Congress. Here's the Conyers bill, an expanded and improved Medicare for all, H.R. 676, and a similar bill in the Senate put forward by Bernie Sanders, and this is the old number. It should be, for some reason, I I made a correction for this. It's, I believe, Senate 1782. And I think there is real, still popular sentiment in favor of this approach. Here's a poll from the New York Times. Overall, do you think the benefits from government programs such as Social Security, Medicare, are worth the cost of those programs for taxpayers, or are they not worth the cost? 7% of people answering this felt they were worth it. But the amazing thing is, if you identified yourself as a Tea Party person, 62% of them felt that Medicare and Social Security were worth the costs. So in summary, what can I say? A single-payer system or a system based on private health insurance plans will not lead to universal coverage, will not create affordable insurance, but a Medicare for all system can lead to universal comprehensive coverage without costing more, has the greatest potential to increase choice and improve quality and expand primary care, and can be financed fairly. So what's going to happen? Well, here you see a graph that describes how the average household income will increase over the next 40 years. And here you see what will happen to the cost of health care over those 40 years, such that by 2038, an entire person's household income will be consumed by health care, a condition not compatible with life. So, people always ask me at the end of this talk, you know, is the ACA a step forward or a step backward? Certainly there are people who believe it's a step forward because it expands coverage, you know, through Medicaid, through subsidies to buy private health insurance. But there are certainly folks who believe that it's a step backward because it's giving taxpayer dollars through these subsidies to private insurers. My conclusion is that the ACA is a great leap sideways. We must go beyond the ACA to a single-payer system. And I like this paraphrase of the Martin Luther King quote. He said, the arc of history, he said actually, the moral universe, is long, but it bends, he said, towards justice. I would argue it bends towards access to health care for all.